Hello, good morning. So, we will be taking a class on anxiety and fear related disorders. This is how it has been spelled in ICD 11. And I should acknowledge Dr. Shantanu for his slides. And also, I have taken some of the slides from World Health Organization, one of the presentations during the ICD 11 during the ICD 11 training. Anxiety as a normal phenomena. Do you feel anxiety? Yes. I feel anxiety. Yes. Everyone feels anxiety. So when there is an exam, you feel anxiety. When your exam result is going to come, you feel anxiety. So experiencing anxiety is a normal thing. If you don't feel anxious, then there is something problematic, right? So how do you feel when you feel anxious? It's a kind of a diffuse, unpleasant, vague sense of apprehension, often accompanied by some autonomic symptoms like headache. You start having some palpitations. Sometimes you feel sweating, or something is going to happen. Then you sometimes you feel tightness in the chest. Also, you feel tightness in the. You feel like choking kind of a sensation. Your stomach might be a little upset. You feel little restless. You find it difficult to sit at one place or stand at one place. So next, you need to differentiate between what is fear and what is anxiety. So fear is predominantly situational. So if you see a tiger, then you start either fight or flight. Okay, so that is fear. Whereas you have to go to a you have to go to a forest. You don't know whether there is a tiger or a lion inside the forest, but that makes you feel a little anxious. That makes you feel alert. Okay, there is some impending danger, and you have to take some precautions. Either you go in a jeep, how to deal with the threat, or you carry a weapon, how to handle the tiger. So both fear and anxiety are two different emotions which are also negative emotions. So fear is a sudden response to a known, external, definitive, or non-conflictual threat, whereas anxiety is insidious response to a threat that is unknown, internal, vague, or conflictual. So what symptoms do you find when a person is anxious? So you can have physical symptoms like there can be motor and visceral effects. There can be psychological symptoms. So there can be an effect on thinking, on perception, and also on learning. So these are the two kinds of symptoms that you can see when a person is anxious. So for a person can have palpitations, restlessness, tachycardia, tremors, stomach upset. So these are the some of the common physical symptoms that you see. In terms of psychological symptoms, you might be finding difficult to focus, you might be confused, you might be having a lot of thoughts about the event. So these are the common psychological symptoms that one might observe. So what is pathological anxiety? When the anxiety is persistent, pervasive, inappropriate to the situation, and the response is excessive to the given stimuli, either by virtue of its intensity or by duration, then you can call it as pathological anxiety. So, what is the prevalence of anxiety disorders in general population? As per the National Mental Health Survey, it is around 10%. Uh, So among anxiety disorders also, generalized anxiety disorder is the common anxiety disorder among the all anxiety disorders, and panic disorder is the most common anxiety disorder that comes to the clinic. So how does ICD-11 classify anxiety and fear related disorders? So there are different kinds of anxiety and fear related disorders that are labeled in ICD-11, and among them the most important is agoraphobia. I will be explaining in detail about each of these disorders. So there is agoraphobia with panic attacks, social anxiety disorder with panic attacks, specific phobia with panic attacks, separate panic disorder. There is generalized anxiety disorder with panic attacks. There is mixed depression and anxiety disorder, separation anxiety disorder with panic attacks, selective mutism. Okay, so let's discuss about these disorders individually. You need to rule out coexisting medical conditions, systemic conditions when you get a case of anxiety disorders. So there are certain common coexisting medical conditions which can mimic like anxiety disorders. If you label them as anxiety disorders, then you might miss the coexisting medical condition. For example, a patient presents with panic attacks, so you need to rule out whether there is any uh, angina or whether there is any arrhythmias. So these needs to be ruled out. A simple ECG can rule out some of these symptoms, some of these clinical conditions. Asthma can also present like panic attacks. Drug withdrawal, alcohol withdrawal can have significant anxiety symptoms. Drug intoxication, like cocaine intoxication, can have severe anxiety symptoms. Recently, one of our group of students have seen case of uh, person having anxiety symptoms under the influence of cannabis. So you need to rule out all these conditions before you go ahead and start any treatment for anxiety disorders. So coming to individual anxiety disorder, first we will discuss about generalized anxiety disorder. Whenever you are differentiating one anxiety disorder to other anxiety disorder, it is the apprehension towards which the person has anxiety. In a generalized anxiety disorder, a person have anxiety towards almost all the situations. So it is persistent, pervasive, worry or apprehension associated with other psychological or physical symptoms, and it is not related to any particular trigger. So that is in terms of generalized anxiety disorder. In this slide I have highlighted some of the important things that has changed, that has been highlighted in the ICD-11. For example, ICD-11 gives more elaborate set of essential features compared to ICD-10. So in overall, a person with generalized anxiety disorder will have anxiety in not restricted to a particular situation but each and every situation. So coming to panic disorder, the typical feature of panic disorder is having panic attack, and the most important thing that we have discussed is apprehension towards what? The apprehension is apprehension towards having another panic attack. For example, a person heard that his friend has been diagnosed with COVID. Suddenly, he was with him the previous day. So he starts feeling anxious. Something is okay. My friend has COVID. So whether I also might have COVID. So then he starts having the palpitations and might have had a panic attack. So that is the triggering event. But the panic attack is so severe, he started feeling that he also had COVID, or he also started feeling that he might die. So the next attack happens because of the apprehension whether I have had a, I might have a panic attack. So the apprehension is towards having a another panic attack. So that has to be established if you wanted to make a diagnosis of panic disorder. So panic attacks are sudden paroxysmal brief episodes of mounting anxiety symptoms, again associated with severe autonomic symptoms and signs, sense of impending doom that something is going to happen, choking like feeling, hyperventilation, a person starts breathing like an asthmatic attack, anticipatory anxiety. So this is the apprehension of having another attack. So there are panic attacks. Panic attacks can happen in wide variety of conditions. So if the panic attack happens within a condition, then you don't like diagnose it as panic disorder. You diagnose it as agoraphobia with panic attacks, generalized anxiety disorder with panic attacks. But in case you are not able to identify these things and apprehension is about having another panic attack, then you diagnose it as panic disorder, and it is very important for you to rule out other cardiovascular conditions. So again, I have given some information about its importance in ICD-11. Same thing. Earlier it used to be agoraphobia with or without panic disorder. Now panic attacks as a specifier has been given for various disorders. I will not go deep into that. You can read. So basically, agoraphobia is in ICD-11 has been reconceptualized as marked and excessive fear or anxiety that occurs in or anticipation of multiple situations where escape is difficult or help is unavailable. So you have to focus on this term where the escape is difficult or help is unavailable. The focus of apprehension here. So always we have been discussing about the focus of apprehension. In the earlier generalized anxiety disorder, the focus of apprehension is general. In panic disorder, focus of apprehension is fear of having another panic attack. Here, the focus of apprehension is fear of specific negative outcomes occurring in the situations that would be incapacitating or embarrassing. So, if you go to a mall, so the fear is that I might get an embarrassment and I may not be able to escape this situation. So, what the person does? The person avoids going to the mall or situations where situations where he find it difficult to escape. So, which is associated with intense fear or anxiety. Phobia. Next comes the specific phobic disorders. In these specific phobic disorders, there are different categories like claustrophobia, pyrophobia, hydrophobia, where the apprehension is towards a single stimulus, towards a specific stimulus, and it can lead to panic attacks also. It can lead to avoidance also. People can have phobia towards injection. So it can be situational, it can be an animal, it can be a natural environment. So a person can have phobia towards uh, different environmental cues. So this is called as specific phobic disorder, and it can be associated with anxiety symptoms, avoidance behavior, and it can also have panic attacks. So next is a social anxiety disorder or social phobia, which you will be seeing most commonly during your posting. Here, the apprehension is predominantly towards the social context, where a person in the social context fears that he has been scrutinized, evaluated, mostly by unfamiliar people, sometimes by familiar people, and starts feeling embarrassed and starts having different kinds of symptoms like blushing, twitching, tremulousness, lightheadedness, choking, fear of being evaluated, and interestingly, anxiety is generally absent in other conditions. Here, the apprehension is predominantly towards the social context. So that is very important here. And you will find avoidance. A person avoids going onto the stage and talking. A person avoids attending weddings because of his social anxiety. So these are commonly seen symptoms. The major change in ICD-11 in terms of social anxiety disorder is the name. The name has been changed from social phobia to social anxiety disorder, and specifically ICD-11 suggests that in children, social anxiety disorder should be differentiated from normal age-appropriate fear and shyness. Two more important things that you need to know is acute stress disorder and post-traumatic stress disorder. So, acute stress disorder generally in case of a significant stress, for example, death of a near one, there is a road traffic accident, there is an earthquake, there is a tsunami. So, following a significant stress, a person can have anxiety symptoms, which generally start immediately and it remits within 3 or 4 days, maximum up to 1 month. But if it crosses 1 month, then you should think of a diagnosis called as post-traumatic stress disorder, which I will be telling about some of the symptoms of post-traumatic stress disorder. And not everyone who encounters this stress can have um acute stress disorder. So a proportion of population can have acute stress disorder. Among people who have acute stress disorder, a proportion can have post-traumatic stress disorder. So if the symptoms persist for more than 1 month after exposure to a severe trauma like road traffic accident, earthquake, tsunami or 9/11 attacks, and so then you should think of post-traumatic stress disorder. So what are the symptoms of this post-traumatic stress disorder? So there is an experience of significant traumatic event Following the experience, a person continues to re-experience the same event. It can be in the dreams, it can be with cues, a person going through the street, remembering about those events. It can be spontaneous, it can be with cues also. There can be hyperarousal symptoms like difficulty falling asleep, irritability, anger outbursts, difficulty in focusing. There can be hypervigilance, exaggerated startle response, and a person tries to avoid the triggers, like tries to avoid the thoughts about the event or any conversation that triggers this re-experiencing situations, persons or places, and the avoidance is there. So these are some of the core symptoms of post-traumatic stress disorder. One of the important things is that the stress should be serious. It should be a serious or perceived to be serious. So there is separation anxiety disorder where ICD-11 suggests that it can be diagnosed both in adults as well as in children, where the anxiety symptoms are predominantly because of separation from the attachment figures. So the focus of separation is separation from the attachment figures, who has been with whom the person is deep in a deep emotional bond. Multiple theories have been proposed for development of these anxiety disorders. So there are theories by Freud, there are behavioral theories based on social learning and conditioning, there are existential theories which suggest that anxiety disorders, actually the anxiety was something which is good when during the age of hunter gatherers, where you are living in a forest and you need to be a little anxious to actually uh, guess the threat that is going to come. But that kind of situation is not there currently, so you are not in a situation where you need to be anxious. So the genes which are actually uh, kind of uh, kind of helping at that point of time are causing anxiety symptoms at this point of time. So that is one of the theories. So there are also neurobiological theories like neurochemical theories, neuroanatomical theories, where neurochemically it has been observed that predominantly norepinephrine, serotonin, and GABA are predominantly mediating the anxiety symptoms. In terms of neuroanatomically, amygdala, limbic system, and hippocampus are predominantly mediating the predominantly mediating these anxiety symptoms. Again, genetics has been shown to play a predominant role. As I was talking about, the genes which are responsible, which are useful genes at one point of time, may not be useful at this point of time, but still those genes tend to continue, which can be leading to anxiety symptoms. Apart from that, serotonin related genes and COMT genes has been implicated in development of anxiety disorders. So there are three temperamental traits which actually makes a person vulnerable to develop anxiety disorders. So one of the important traits is behavioral inhibition. It is a heritable trait. It is characterized by restraint, caution, or fearfulness, and withdrawal in response to unfamiliar or novel people, stimuli, or situations. And it is associated with greater amygdala response to novel stimuli compared to non-behavioral inhibited children. This is one trait. Second thing is anxiety sensitivity. It is a fear of anxiety related situation based on the belief that such sensations are harmful. The third important trait is neuroticism, a personality trait that predisposes individuals to higher negative effect, has been rigorously studied for several decades and has been strongly associated with common mental disorders in general and internalizing disorders, including anxiety disorders in particular. So how do you manage the anxiety disorders? So by now you would have understood that taking a good history is very important. Do relevant physical examination, look for any symptoms of hypothyroidism or hyperthyroidism, get all the lab investigations done. For example, hypothyroidism and hyperthyroidism, you know that it can lead to anxiety symptoms. There might be situations where you need to get cortisol levels. You might have to evaluate for pheochromocytoma in some cases. So ordering appropriate lab investigations is also important. So there are two types of management. One is pharmacological and non-pharmacological. In terms of pharmacological, you target the receptors which are implicated in anxiety disorders. So you target GABA by benzodiazepine, you target serotonin receptor by antidepressant or anti-anxiety drugs. uh, yeah, one thing that you need to remember is that don't give benzodiazepines for more than 2 to 4 weeks, because long-term use of benzodiazepine has not been recommended for treatment of anxiety disorders. The next important thing is non-pharmacological management. CBT has been used for cognitive behavioral therapy, has been used for various anxiety disorder, and it is the most evidence-based. Systematic desensitization has been used for specific phobias, and exposure response prevention has been used for specific phobias, and most importantly for social anxiety disorder. So these are the three main receptors at which the anti-anxiety medications work. One is GABA A, as I told about benzodiazepine. 5-HT transporter, where SSRIs and SNRIs act. 5-HT1A, where buspirone acts as a partial agonist. So the floor is open for questions, and Manul can take over for relevant questions and discussion. Thank you.